And there you are. Today, we're going to continue part 2 of our interview with Dr. Anthony Nicholson, all the way from Australia. I'll tell you more about him in just a minute, but Dr. Nicholson is a fountain of knowledge nuggets, just like I said last week. So don't go anywhere, because it's about to get good. First, here's that "So Glad You Stopped By" bumper music. Okay, we all made it back, and it's good to have you here. Welcome to the podcast today. I'm Dr. Jeff Williams, and I'm your host of the Chiropractic Forward podcast. You have cavorted right into episode number 71, and we're so glad you did. We're here to advocate for chiropractic, while we also make your life easier. Part of doing that is having the right patient education tools in your office. Tools that educate based on solid, researched information. We offer you that. Already did it for you. We're taking pre-orders right now for our brand new evidence-based office brochures available at chiropracticforward.com. Just go over there, click the store link at the top right of the home page, and you're off and running. Shoot me an email at dr.williams@chiropracticforward.com if something seems out of sorts or you think something's not working right. We're here to fix it. We're here to help you. We want to get it in your hands. I can't wait to get them in my hands. If you're like me, you get tired of answering the same old questions over and over. Well, these brochures, they make great ways of educating while saving yourself a little bit of time and breath and some energy. And we all need more energy, don't we? They're also great for putting in take-home folders, so don't forget that part of it. Go check them out, chiropracticforward.com, right up under the store link. While you're there, sign up for the newsletter. It's just an email. We're not going to spam you. Just one email a week to remind you when the new episode goes live, and that is it. Now, we won't go in too deep here on the latest DACO endeavors because we have Mr. DACO teacher and educator with us again this week. So again, just in case you don't know, the DACO stands for Diplomat of the Academy of Chiropractic Orthopedics. I'll say quickly that I have completed the Pain in the Frame Symposium part of the course, and it was probably my favorite. It was really, really outstanding. Also, I'm only 29 hours away from finishing all 300 hours at this point, and it's all gravy now, folks. So I'm back onto the communication drills, which go fairly quickly, and they're not too incredibly stressful or taxing on a guy such as myself. Now, I covered this in part 1 last week, but for those that don't know anything about this Aussie from down under or why we would be having him on the Chiropractic Forward podcast, let me take just a minute to introduce him again properly. Dr. Anthony Nicholson is the CEO of Chiropractic Development International, a global continuing education organization for chiropractors, and he co-founded this back in 2002. CDI's innovative online learning technology has led to formal accreditation in over 35 states in North America, along with a growing learner base in the UK, Europe, and Southeast Asia. The CDI program provides 250 hours of advanced online clinical training for the Neuromusculoskeletal Medicine Program, offered through the University of Bridgeport in Connecticut, which you've heard me talk about. And it developed an online board examination for the Academy of Chiropractic Orthopedics. As a partner of Spine Partners in Warunga, we're going to make sure I'm saying that right, but Warunga in Sydney, Australia, Dr. Nicholson is also a full-time chiropractic physician in private practice, is a board-certified chiropractic neurologist, and is a board-certified chiropractic orthopedist. So, pretty accomplished right there. In addition, he's an adjunct senior lecturer in neuromusculoskeletal diagnosis and evidence-based practice at Macquarie University in Sydney's North Shore. On a personal note, like I said, I can tell you listeners of the Chiropractic Forward podcast, you've heard me talk about it a million times. If you do indeed sign up for the DACO program through the University of Bridgeport, anytime you get to the video-based learning, it is Dr. Nicholson right up front in all the videos, being all smart and teaching you the stuff you need to know. So I feel like I already know Dr. Nicholson just from watching all of these videos. He's completely on the other side of the planet from me when we are speaking. So there are some drops in the audio, but just stick with it because the information is outstanding. And none of the drops are too bad that you can't follow what is being said, okay? So while I understand it can get a little annoying, and also understand we are limited by technology, which is still amazing to consider that we can have a real-time conversation on complete opposite sides of the planet. If you didn't catch part 1, make sure you go back and listen to that right now. And then you come back and listen to part 2, okay? You're going to love it. So with that said, let's get on with part 2 of the interview. I'll tell you what, let's get into CDI a little bit. But before we do that, let's talk about why you think it's important to specialize or get credentialed. I mean, obviously, I'm going through the DACO, so I know it's important. You know it's important. But you might phrase it in a way that resonates with somebody. So I kind of wanted to hear your thoughts of why you think it's important to specialize.
Well, I think... certainly, I think what you're doing is create a higher minimum standard. I think quite simply. I think as I mentioned before, mature professions are stratified. I think we need to recognise more advanced diagnostic skills and communication skills and attach and link appropriate privileges and positions in the healthcare hierarchy to those skills. So I think we need, as a profession, to stratify in that way to demonstrate leadership, to recognise more advanced skill sets and knowledge. And so that's why I think becoming board certified is important. I guess it's a bit like over here, certainly, an accountant versus a CPA. I mean, it's a higher minimum standard that you can rely on. So that's why I would encourage chiropractors to pursue this. I think, Dr. Lehman has already been on there quite eloquently describing how our future integration and our future participation is going to hinge upon a clinical credential, not necessarily research, but a clinical credential demonstrating, our more advanced skills and knowledge.
Yeah, boy, that was a big episode too. A lot of people listened to that one. So now, for those that. Yeah, he's great. But for those that don't know what CDI is, which is you and Dr. Long's company, give us a little bit of a description. Tell me what you guys do. Maybe what's the mission? What is the International Neuromusculoskeletal Medicine Program? What exactly you guys got going on over there?
Okay, well, look, I think CDI over the years, as I mentioned, it started out with a heavy focus on professional communication to help chiropractors build sustainable practices through referral relationships off the back of clearly communicating what it is that you do and being, and developing mutual respect for that. Then along the way, really the mission has been to create a clear identity for where the chiropractic profession is positioned in the healthcare hierarchy and the landscape, our role. And I think if you look at the future needs, and I remember great papers by, I think it was, you've got the likes of Murphy and Pearl and all of these, where, they tell us that society really grants a franchise in a way. Society has a massive problem that it needs solved. And so it wants a profession, a group of skilled individuals to deliver upon that. So if you look at what the greatest need is, I think that is pain in the frame, the way we put it simply. So the diagnosis and management of neuromusculoskeletal conditions. Now, I say conditions because it doesn't necessarily mean just pathologies, but we're also talking about reasons for reduced quality of life or performance, under potential, all sorts of things. But really, across the neuromusculoskeletal scope of practice, we design clinical programs that would match what walks through the door every day. I think a lot of us like to think that, a lot of people are coming in just to be well, but I think at the end of the day, when you really look at it, people are walking in with a problem to be solved. They're walking in because of some sort of pain in their frame, and they want help. And so, here we are, a profession skilled to do it. So we went from seminars, live workshops, which frankly we were travelling 20 or 30 weekends a year. We were running programs across Australia in 5 cities, Auckland, Hong Kong. And it was around about that time, I guess, 2006, 7, 8, that the online learning sort of medium was starting to develop. And we were an early adopter over here. And I remember discussing this with Matthew and saying, look, we really need to allow chiropractors to experience learning in the same way that they continue to learn in practice. And that is a shift from a didactic approach. I mean, if you look at the way formal education is structured, it's very much topic-based. You start with a condition or a diagnosis. You start with a diagnosis and then you work back and describe it. But that's not how you learn as a doctor, ongoing, as a chiropractor. People walk through the door with a problem that needs to be solved. So it's really the opposite. And not only that, it's not topic-based. You don't do shoulders on a Monday and necks on a Tuesday. So we said this online education needs to be different. It can't just be a synopsis or a PowerPoint on the web. It's got to be as if you were dropped into an experienced doctor's practice, sat beside them, and experienced their day. So we said it needs to be what walks through the door next. So we developed then some online programs in a different way, filmed from the doctor's perspective, like the e-learning episode, but also other drills in diagnosis and communication where you would be presented with problems to solve, both from diagnostic side and communication side, every day walking through the door. And what if we pulled the latest evidence? What if when you were going through your day and solving problems and treating patients, what if at any moment, just at the point when a decision needed to be made, you could draw on some of the latest evidence to guide you? So it's really information that is formatted in the way it's immediately applied and used just when you need it to make a decision. That was our, guiding set of principles for developing the online programs. And we wanted that to then match the core scope of practice of chiropractors and how they would be able to position themselves with authority in the future to match society's needs. And that's really I remember then finding my way and getting in contact with Dr. Lehman. And from there, it was really a nice marriage. We wanted to build a program that would, give chiropractors a really good, clear framework for, their practices, their day, and advancing those skills and generating referrals. Yeah.
Well, you guys, you hit the nail right on the head, because when you open up a course, you're presented immediately with, Claire, she's 20 years old, comes into your practice, and here's what's going on with her. So my listeners, they've been very well aware. They've been schooled up on the DACO courses a little bit and all the different types of learning through your CDI platform. So I've told them there's the e-learning courses that you're on screen talking, so I feel like I already know you before I even got on Skype with you. But then there's the diagnostic drills, communication drills, learning how to communicate with those in the medical profession. Then the pain in the frame series, which I just finished up last week, which was excellent. There's another one on dizziness. I haven't decided whether I'm going to tackle that one or not, but we'll see. But
depends on how much of a sucker for punishment you really are.
Yeah, I know. So anything else you'd like to add about all the different types of courses?
I think that, in my mind, encapsulates it fairly well. I think, I'd again just want to emphasise that our continuing education really needs to be experiential and practice-based and problem-solving based. And I think that's where it's headed. We still get a lot of questions, for example. I mean, people still sort of think, now, look, where's the topic outline and that? And that's a common question we get, and it's understandable. And people want to know where to start and all those sorts of things. Now, to some degree, the communication drills, we've just refined those and rewritten a lot of those. Those that are better to do it in a certain order, but the others are designed to be like you don't know what next will walk through your door. You don't know what's going to walk in tomorrow. So that's the way, for example, a doctor would learn on an internship with rounds and a hospital rotation. It's what's next. That's the way it's designed. That's been a bit of a new concept for many doctors to get their head around when they start these programs. Once you get the hang of that, though, I think it works very well because it sort of starts to match your day. You go, oh, look at that. It's almost like you just do a drill on, for example, hip pain in an adolescent, and in comes a limping child the next day with hip pain.
It's ridiculous how that happens, but it absolutely happens that way. So tell me a little bit about Dr. Long. Okay, so you met him in school, and you're the one teaching the courses. You do the e-learning courses. You do the pain in the frame. We never see his face. Is he like the wizard behind the curtain, or what's going on there?
See, well, that's because he's usually behind the camera, would be the answer to that. I mean, Matthew's other love, I think, if he didn't become a chiropractor, it was going to be either something in IT or perhaps even cinematography. Matthew's real passion is Final Cut Pro. He's on the creative side with cinematography. So he's the one that really puts together all of the engaging and experiential feel to our learning programs. And that's another thing we wanted to do as well. Not just use just a bit of a handy cam and just try and get the best sort of version we could, but actually as if it's a cinematic experience, because you're really then engaging the senses in a very complete way with your learner, because we know that learning happens really at so many levels and all of these sensory experiences. So we really wanted to ensure that it was, especially Matthew, that it was really top quality in that way. So that's partly the reason. Is Matthew's behind the scenes a lot with creating a lot of the visuals and all of that. But there's also, obviously, we meet regularly, is heavily involved with keeping our research database up to scratch. We've got thousands upon thousands of papers that we're always processing and reading through, and it's very, very good to just bounce ideas cerebrally off each other. And then that's distilled down into what we actually present.
Well, he does an excellent job. I remember talking to Dr. Lehman in one of his DACO live hours that we did down in Dallas, Texas, and he was commenting on how sharp the video is and how good it looks. He said, man, it looks like Hollywood. So you'll have to tell Dr. Long. We think it looks like Hollywood. So
very clear.
Yeah. So now, have you done? You just mentioned how much you love research, and I know how much you refer to research and all this good stuff. So, have you ever been involved in your own research, or are you thinking about doing any of your own studies?
Well, look, that's a good question. And if I really were to express a frustration in my daily life, it would be that the time taken to build educational library like we've done and continually refresh it and teach and in practice full time as well is the time that I don't have to really satisfy my ambitions there in research. I think that you could really look at three main roles here: that of clinician, researcher, and educator, and that I see my role as somewhere is in between there. Reading research, absorbing it all the time, but then distilling it as a clinician myself and building a bridge between what happens in research and what's happening at the patient interface and delivering that in a usable fashion. So I think that's been my central role. That being said, I've got numerous manuscripts on the go and almost done, one being, really on professional communication and documenting our work. And in many ways, each learning episode is a case report in itself that I could have had published, because it involves combing the literature for insights and and writing up those cases. So
you got a point there. You're probably right.
I do have a passion. Yeah, exactly. So I do have a passion for it. It's been a gap so far that I do wish to fill, but I see. Look, my primary role is one of educator and clinician.
So I have heard about you guys through email or I'm not even sure where I heard it for sure, but I've heard you guys mention that you're working on some other stuff. You're updating some of the communication drills, some things like that. But in general, tell me what's next for CDI. Where are you going with it all?
Well, look, I think that's a good question. I think at the moment, certainly our very clear mission is to further build the Neuromusculoskeletal Medicine Program and see if we can get more chiropractors, contributing to this. I guess the legion of chiropractors that are really going to be our future and taking that forward. From there, look, I really would like to see. We really would like to build a more comprehensive research for medical doctors, and that is we've done presentations and education at times before for them. We've often done seminars for our local medical community in terms of, chronic spine pain, latest concepts in pain science, how that's being tackled, and differential diagnosis. So I'd really like, I guess, a resource base for them. I think we really need to bridge that gap. I don't particularly like the term alternative.
Right.
I think we all work together and mutually respect each other's expertise. So I'd really like to, I guess, with CDI branch a little bit more in that direction where we start to bridge to the other side a bit and provide some resources there. We've done a lot of interviews, a lot of experts, and certainly that has built a lot of connections. So and possibly even contribute to their educational process from our perspective. Come in and say, well, look, this is what it might be like. This is what it might be like to work collaboratively with a chiropractor in these types of cases.
Well, do me a favor. After you get all of your medical doctors all schooled up, can you come over here and get ours schooled up? Because they are just terrible sometimes. So, I remember I'm in Texas. We're under attack right now, so I have a negative attitude.
Yes. Yes. So I was going to say, look, it is frustrating when there's generalizations made. We're all tarred with the same brush.
Yep. I agree. Do you feel like, I feel like part of it is part of the blame for that sort of negative attitude is a lack of standardization in our profession. You never know what you're going to get. And that's frustrating for all of us, I think. And it's frustrating for them. Do you feel like chiropractic standardization is something that's even attainable? I really have a hard time seeing how the two sides of the profession will ever maybe not unify, but even meet on any sort of common ground. What do you think our profession is going to look like in another 15 to 20 years?
Well, I think that's a good question. And I think you're right. I think it is what makes it so difficult to refer, I guess, if we look at the medical practitioner's perspective, is that it's hard for them to have confidence. They tend to build relationships with individuals irrespective of what they're called. And that's what we've found, that you build very individual relationships, rather than refer to a chiropractor, because they don't really know what that's going to entail. And so I think a lack of very, very clear identity, scope of practice, and an understanding of what you'll get is a big part of the problem. And that's a central, goal of the Neuromusculoskeletal Medicine Program and the credential. A credential means something. A credential will be, I know what I'm going to get. I know I'm going to get this level of diagnostic expertise, and I know I'm going to get this level of professional reporting and communication, much like you would from any specialist. There's a culture there. So I think if we build that cultural identity, then they will have that confidence to refer to an individual that has that credential. Now, as for the broader profession and whether we can all come together, look, I'm a bit of an idealist. I think it's not out of the realms of possibility. I think it won't be easy. But I think what it comes down to is this, Jeff. I think if the model and framework is clear enough, I think the evolving neuroscience of what we're really doing will continue to bring us all together. And that goes for, I guess, a lot of the professions that are that use hands-on techniques. And I guess this question probably merges into another one that, that we get commonly about what makes us unique from other professions that also use hands-on applications.
You're about to answer my next question.
Ah, right, okay.
Can I ask it real quick?
So this first question. Yeah, go for it.
Okay, well, if evidence-based chiropractors are mostly focused on resolving musculoskeletal pain, what makes us any different than physical therapists?
Well, look, I like this question. I really do. And it depends how much time you've got with your listeners here. But I love a good chat on this topic. Let me try and more completely answer that last question and this at the same time, because we could go down all sorts of rabbit holes here with definitions, and I think the danger with that sort of question is looking at it too closely. Narrow perspectives are like using a flashlight in a dark library. I think we need to zoom out and look at the big picture. And this is the sort of analogy we use with trying to get on the same page as a medical doctor. We use the analogy, two ants sitting on a wall and one ant says to the other, the world is definitely blue. And the first ant says, no, the world is red, definitely. And then you take both ants to the other side of the room and suddenly they both appreciate the beauty of the Picasso painting that they were both sitting on. And I think if we do let's do that same sort of little exercise right now. I think it's important to understand and appreciate really the history here, and that is that manipulation predates all health professions. In fact, we might just be talking about the oldest form of healthcare in existence. We know it's depicted in cave paintings in early man, where one manipulates the other's joints. But the first really comprehensive documentation of manipulation was by Hippocrates himself 2,500 years ago. We know he had tables that looked much like ours than you'd see in our practices today, and he documented many, procedures like what we'd use. So we're really talking about the application of physical force therapeutically with healing intent. And so that remained synonymous with healthcare, or call it medicine, but the medical profession hadn't established that. But it was really synonymous with medicine for the next 16 to 1,700 years. And we even see, documents in one of the most famous surgeons in ancient Rome, Galen, documents a patient coming in with tingling in a hand and using neck manipulation to successfully treat that. Now, that's long before we understood nerves or anything. It was possibly blocked humours or whatever it was. But it was used right back then. Then we don't see until the 1800s really a few professions start to crystallise and form around the use of manipulation. But we're talking about it was at medical conferences, it was written up in journals, there were special editions. It was it before pharmaceuticals and the germ theory started to emerge. And so it remains today as one of the most effective, cost-effective, patient-satisfying forms of healthcare in existence. So if we really look at it that way, it starts to bring it into a different light. So manipulation itself has never really been questioned as an effective tool. What's questioned, and this is the big issue, is the credibility. The claims made around what manipulation can do. Now, and this is where I think, this is what differentiates us, is we need a framework that is at the leading edge of our knowledge base, that's plausible, that has a great rationale, that uses modern neuroscience. And if we have a framework for then saying this is how it's used and what we do, then that's, I think, going to define our uniqueness. So let's just say I said to you, that I'm going to manipulate a certain part or adjust a certain parts of a patient's spine. I mean, chiropractors will call a very refined form of manipulation an adjustment. Now, I think most patients still see that in a very mechanical paradigm. They still understand a rapid physical force to have a local effect. But the question I think the framework has to answer is this: how could a rapid displacement of tissue that lasts less than a tenth of a second change the behaviour of the central nervous system in a way that outlasts the intervention itself? So I think back in the 70s then, we started to understand that really there's something about proprioception going on here. Core and Gillette and these people started to actually define the sensory machinery that was present in the axial skeleton. We started to understand what that was connected to in the brain. We started to understand that, you know what, the brain understands where the mechanical parts are based upon length data from muscle. That data goes straight to the brain, and the brain pieces together the length of all your muscles to know where your joints are. And that when we adjust a patient's framework, perhaps we have worked out unwittingly, and this happened right throughout history for thousands of years, we worked out a way of unwittingly exploiting an inherent signalling property of the muscle spindle apparatus, the receptor that reports muscle length. We worked out how to exploit that and are leveraged in a very, very leveraged way to influence the responsiveness of the brain and how the brain maps and understands those joint positions. And that's plastic. It's usage dependent. We live in a less physically demanding world, so patients don't move around and use all of these articulations, and what's not used is underrepresented in the brain. And we know from the latest research that we have these blurry maps in the brain with people with chronic pain. Their brain has a shrunken understanding of how their body even works, and that an adjustment may very well expand out that sensory understanding again. They start to stabilise and restore control. And so if we're a group of professionals now, let's say we're a group of expert diagnosticians that understand pathology and people when they've got something serious going on that need referral. Beyond that, we then say, you know what, tissue failure does occur because when you've got a failing system, you're going to damage structures. We can identify those two, differentiate between those pain sources. You know what, how did you get here? What has failed? How have you deconditioned both in your brain and in your tissues? Because understand, when someone gets better, it's not just their body that's looking buffed, their brain circuitry looks buffed. We're strengthening the brains of our patients when we manipulate, then send in these leveraged inputs. So we then understand, well, here's what's failed from a proprioceptive perspective and a deficit, and we need to actually strengthen and rehabilitate that again over time. If people are in chronic pain and they have these deficits left unattended to, then we know that takes on a psychological dimension. We know that they make poor emotional decisions. They make poor dietary decisions. They don't move well. They get depressed. Now they start to lose their job. Now, it's not too difficult to get from apparent mechanical pain source to the entire well-being of this individual and how we might contribute. Now, I ask you, if we are seeing our patients day to day on that basis, then is that not our uniqueness? I mean, do we really need to, say, get down to tin tacks and say, we'll do this, they'll do that? I think if there's a framework that's strong enough, a model that's strong enough. See, the problem is if people have got a weak model that's limiting and that's full of contradictions, you're not even going to let go of a weak model to have no model, because you're thrust into massive uncertainty and you wouldn't know what's an overwhelming amount of information you couldn't work on a daily basis. They need a stronger model in order to release an older model. Now, as I said, I'm an idealist. I think that we can all move to a stronger model together and all be satisfied in a way that our uniqueness is preserved.
You know,
That's my short.
I feel like, first of all, if I weren't already signed up as a chiropractor, I might just sign up after that. But also, I feel like maybe we should charge our listeners for sitting through that, because that was really good stuff. I hope everybody really paid attention to that. So
I love a good chat about that stuff.
Oh yeah, and I've heard you talking about most of that, so it's familiar to me. But I'd like to sit and watch somebody listen to that with fresh ears that had never heard it before. So I'm interested. I'll have to ask some of my buddies. Isn't it?
I mean, if you look at, some people will take a look at a regional problem, look at it in a regional way, the area that hurts. But I think if we brought all chiropractors together, we take a global look. we view the entire joint system as one interconnected whole, as one organ. And I think you could probably say, so I think if we focused on what brings us together and what unifies us and what's common, then I think we can all move together, but forward. But plausibility is the name of the game here. If we aren't plausible, if we aren't explaining the effects of what we do day to day in a way that you could describe to anybody, no matter what their discipline, it's a common terminology, it's science, it's the advancing knowledge base, but yet preserves our uniqueness. If we're able to do that, then look, I think we can come together. I do. I hope.
Yeah. Well, you may have me convinced. I'm already more optimistic than I was before I asked the question. So I'm a little jealous of Australia getting you all to themselves. So do you ever travel to the U.S. to do talks, seminars, things like that?
Look, I do. I've been pleasingly, I've had the opportunity to go over and spend time with Dr. Lehman in Bridgeport, the University of Bridgeport, on many occasions, and also speak at a large conference in Florida, in Orlando, and also Las Vegas and things like that. So look, I'm probably going to look at coming over there and I guess doing more presentations as part of this program. And so, yeah, look, I always welcome the opportunity. I'd love to come across and speak again, and try and advance, our standing generally as a profession globally.
So I may actually look you in the eye and shake your hand one of these days.
I look forward to that.
There you go.
Absolutely.
Well, I tell you what, if people are wanting to, maybe they don't know about the CDI yet and spending the money to go through the DACO, but they do kind of want to follow you and hear some more of your ideas and all of that good stuff. Where do people find you online? I haven't been able to find you on Facebook, by the way. You may be hiding. I don't know. But where do people find you online and kind of interact with you, or, you know what people do online? How do they find you?
Absolutely. Well, look, largely through our website. We obviously have an agreement with the University of Bridgeport, and all our programs are presented, through the University of Bridgeport. We also have other, any chiropractor who is going through those programs or interested in those programs can create an online profile through that. Even if they don't, if they're not ready to pursue the program as yet, you can still create a profile through links through University of Bridgeport, which will get you to CDI's site. And you can create an online profile and then browse. There's a whole range of complementary resources, interviews with experts, blog articles. I've also done a podcast, 26 podcasts on neuroscience and neurology underpinning what we do as chiropractors. That's also on our website. I'm not on Facebook a lot because I'm a lot of the time responding to the forums and commenting on our learning programs. That takes up a lot of my time. I also lecture at Macquarie University and in practice, as I said. But yeah, look, we're looking at other ways of, I guess, getting that message out there with some short sort of clinical pearls as well, shorter mechanisms, and so we're investigating that now. But look, most of that takes place through the website. I'd encourage, anyone to at least create a profile, which involves a whole library of different resources, and from there, if board certification or further advanced education is a step you want to take sometime in the future, you can simply then start that any time you like. But an online profile is the first step, and that allows all sorts of engagement.
Perfect. Well, I'm going to let you get back to work, and I'm going to go to bed. So I want to thank you so much for taking time out of your day to join us. I hope our listeners got as much out of our talk as I did, and I know they did. But it's groups like the CDI and specialization programs like the DACO that are really helping put chiropractors where I feel like we should be. So I just want to say thank you for everything you're doing, and thank you for taking time out for us.
Look, thanks so much. I so much enjoyed it, and I really appreciate you asking me to come on your program. I think it's a wonderful program for chiropractors out there, so thanks again.
Absolutely. And so there you have it, the conclusion of our awesome interview with the incredibly scary smart Dr. Anthony Nicholson from the land down under Australia. What an interview, and man, I hope you got to listen to it all, both parts. If you didn't get part one, make sure you go back to last week and get part one, because he is just absolutely fascinating. Whether you like the DACO or think about specializing with the DACO or some other diplomat, Dr. Nicholson is not just a diplomat neurology, but also orthopedics, and just what a talented guy and what an asset for our profession. So there we go. We're going to start closing out here with our message. Every week, the message is that you need to know with absolute certainty when chiropractic is at its best, you can't beat the risk versus reward ratio, because spinal pain is primarily a movement-related pain and typically responds better to a movement-related treatment rather than a chemical treatment like pills and shots. When compared to the traditional medical model, research and clinical experience show that many patients get good or excellent results through chiropractic for headaches, neck pain, back pain, joint pain, and that's just naming a few. Chiropractic care is safe, cost-effective. It can decrease instances of surgery and disability, and chiropractors normally do this through conservative, non-surgical means with minimal time requirements or hassle on part of the patient. And if the patient develops a preventative mindset going forward from initial recovery, well, chiropractors can likely keep it that way while raising the general overall level of health of the patient. And the key point, it always comes down to the key point, and that is that patients should have the guarantee of having the best treatment offering the least harm, and that's chiropractic, folks. Send us an email at dr.williams@chiropractic4.com. Let us know what you think of the show. Tell us what your suggestions are for future episodes. We want to hear it. Feedback, constructive criticism, all good stuff. So bring it on, folks. You know what's also excellent is reviews on iTunes. Oh yeah. Reviews on other podcast services. Hell yeah. You'll know how it works by now. This is 2019. If you like it, you got to interact with it, you got to share it, you got to review it. So help us out, get on it. We cannot wait to connect with you again next week from the Chiropractic Forward podcast flight deck. This is Dr. Jeff Williams saying upward, onward, and forward. Be sure to find me on social media sites such as Facebook, Twitter, LinkedIn, and YouTube. While you're at it, give us a thumbs up on YouTube. That's super simple. Be sure and visit chiropractic4.com. Give our podcast a listen. Lots of wonderful, wonderful information there. And as always, thanks for listening. We'll see you next time.